G'day, Martin.
And Phil.
Phil.
I forgot your name.
It's been a long conference.
It has been a long conference. The next section we're going to just have a wander around the poster section and see what floats our boat.
So here's the end of a very long conference, so forgive you for forgetting my name.
Yeah.
So we're going to have a wander around the poster display. And
very enormous poster display.
We figure there's about 1,000 posters here today that are related to infection prevention control in some way.
Yeah.
And that is just crazy. And we're going to try and get our way through as many as we can that we've sort of piqued our interests. And in this podcast, we're just going to present like between probably 2-3 minutes for a poster and run through them. And we're going to also
try and grab a few authors if we can along the way, if they happen to be there.
Yeah. So, looking forward to, hope you enjoy some of the posters from ESCMID.
Excellent.
Okay, Brett here at ESCMID, and just in front of a poster. It's called AMR Surveillance in Wastewater and Clinical Isolates for Tertiary Hospitals. Preliminary results. It's a study undertaken here in Spain, where ESCMID's at the moment. Author is Francis Cuesta, and I apologise for my probably terrible pronunciations that I'm using for names here at ESCMID. So the background to this was that they were interested in doing, or they did do, and are still doing, metagenomic surveillance to assess the spread of AMR genes in the environment. And they're looking to evaluate the presence of AMR genes in clinical isolates and their spread through hospital wastewater. And they're presenting their preliminary results over the last 2 years. This is a study that's actually going to go for 4 years. They've been sampling clinical wastewater from the hospital, doing metagenomic sequencing on that wastewater. So the preliminary results to date show that, the suggestion is that hospital wastewater is going to be a powerful surveillance tool to detect AMR bacteria in clinical and environmental sources. And that they found that beta-lactamase were dominant in the samples that they identified in wastewater. And they really hope to learn from this study as it progresses through over the years how they can depict the evolution and spread of AMR in wastewater using metagenomics. So presumably then we'll be able to pick up early warning trigger signs of what might be changing within the hospital environment longitudinally and have an early warning system when something goes slightly awry. I guess a little bit like happened during wastewater surveillance for COVID-19. So looking forward to hearing more about that study probably in the next couple of years, I imagine. Bye for now.
So it's Martin now. I'm standing beside a poster from Manipal, which I think is in India. Yeah, Manipal, Udaipur in India, which is called Deciphering the Temporal Short-Term Dynamics of Acinetobacter baumanii, Impact of Colonisation Pressure on Infection in an Endemic Indian Intensive Care Unit. And it's something that I hadn't really thought of before. For me, when we go looking for Klebsiellas, we tend to do rectal swabs and stool samples. Actually, in this particular piece of work, they found that the largest proportion of colonisation was in the oral cavity, which I've just not seen that before. Maybe it's been reported and I've completely missed it, but oral colonisation is likely to lead to potentially different transmission dynamics from it coming out of other parts of the body. So maybe that's something worth thinking about, because there's very high colonisation pressure in this particular study. But what would you do about the oral cavity? Would tooth cleaning actually reduce oral colonisation with Acinetobacter baumanii? Because I can imagine that isn't likely to be a normal part of the mouth flora, although I don't know that. Or would oral chlorhexidine have an impact on oral colonisation? It's an intensive care unit, so is it just the tube that's causing that issue? I don't know, but I've not seen too many other studies that have suggested that. And once you go back to the ward, are you still colonised in the oral cavity? Another thing I don't know. Generally, I'm pretty staggered by all the things I don't know anyway. But yeah, interesting. And having just thought about this for a while, Manasa Tantry, the author's just turned up. So Manasa, can you tell me about this work?
Yeah, this is a part of my doctoral thesis work, wherein we have done a short follow-up cohort study on all adult patients who have been admitted in a particular ICU.
Yeah.
So we have carried out this work for over 18 weeks.
Yeah.
And through different seasons, pre-monsoon, monsoon and post-monsoon.
Okay.
And during each week, whoever has been admitted to that particular ICU, we have screened them for different body sites.
Yeah, because most people just go for rectal swabs, don't they? But you've done different body sites, which is interesting.
Yeah, because oral colonization is a major cause.
Yes.
And we see that more patients in our setting, they develop VAP.
Yeah.
That is why we just wanted to see how many of these patients are colonized by Acinetobacter, particularly carbapenem-resistant Acinetobacter. And we started initially only with oral colonization.
Right.
Oral and from anticubital fossa.
Is this before you start ventilation or after
No.
they've had the tube in for a while?
No, right when they're admitted in that particular ICU. Sometimes they come from the trauma triage with ventilator, ventilator.
Yeah. Okay.
So those patients also we have screened. And that is why we have seen that major of our patients who have been colonized, these were imported carriers, meaning on the day of ICU admission itself, they were colonized by Acinetobacter. That's why we see the percentage of imported carriers in our study population or the study cohort is more. And these 22% of the patients, they acquired the colonization by Acinetobacter once they were admitted in the ICU.
Okay. Now, do you know if the imported carriers were actually in the hospital before they came to ITU, or these are previous hospital admissions?
No, this includes our in-hospital,
Okay.
In hospital, there was transmission from trauma triage or from other wards or from step-down ICUs. If they were critical, they were shifted to the major ICU. So,
I'm just wondering how, if you came through the door of a hospital, how many might carry this? They picked it up since they've come in.
Yeah. So even if the patient has come from the other hospital, they were in the trauma triage for at least for 24 hours, and then they were, shifted to the major ICU.
Okay.
So
it'd be interesting to follow up to see once they've left ICU and they don't have a foreign object in their mouth, and then, well, do they lose it, or do you carry on being orally colonized? Because that brings in a different transmission dynamic with chances of contaminating services through speech. And
so one more, the thing is, the median number of days in the ICU was almost 4 days.
Yeah.
So either the patient succumbed to death, or since these patients were already critical, within 4 days they would either die, or in case if they were transferred out of the ICU also, we have followed up. So in those cases, the colonization was not there, was not seen once the patient was moved out of the ICU.
Okay.
Yeah, because whoever has acquired the infection following colonization have died.
Okay.
Those who moved out of the ICU and whose, if their host factors were better, they have survived, and their colonization is also.
What's your next steps with this piece of work?
We need to look into the genotyping. We have just done the basic, that is the RT-PCR, looking at the different clonality. So we need fund for more of whatever can be done. So for my doctoral thesis, we did not have an idea of what is the colonization proportion. We just knew that the burden is high, the infection burden is high. We did not know how much of the patients were colonized. And right now, if you see, the oral cavity is predominantly colonized.
Yes.
And it is significantly associated with VAP also.
Yes.
We found some, oral colonization was significantly associated with pulmonary infection.
Yeah.
So statistically also it's
nearly 4
significant.
times the risk. Yeah.
Yes.
Yeah.
So more of it, genotyping or the genomic dynamics can be understood by more of other genomic tools can be used. So this is just a preliminary study where we have tried to do some basic tracking.
Yep.
And since as a teaching hospital, it's very vast, and then it's very difficult to track, because if the patient is doing better, he has been shifted out to other ICU, step-down ICU, and then to track each patient is quite difficult.
Interesting. Interesting when, at what point did they acquire it, and then does this become an endogenous VAT?
Yes.
We've been talking a bit about that. But anyway, thank you very much. Thank you for your time. Thank you.
Okay, it's Brett here again at ESCMID. I'm standing in front of a poster called Post-antibiotic Risk for Recurrent Lower Respiratory Tract Infections During Prolonged Hospitalisation. It was a study undertaken in the US. Matthew Zielger is the lead author on this poster. And what they're interested in is understanding how often does HAP and VAP after treatment come back again, essentially reoccurrences of HAP and VAP. and to try and understand whether there were any, what the epidemiology of that really looked like. So they performed a retrospective cohort study at University of Pennsylvania. And during their review, they identified 7,000 patients who are at risk of pneumonia, and found 515 cases of both HAP and VAP combined. The vast majority of those, about 3/4 of those 500, had positive culture for HAP, so they could determine the causative organism. And there was a large number of recurrences. So in the case of VAP, 20% of patients who had VAP got it again. And for HAP, hospital-acquired pneumonia, non-ventilator associated, was around 11 to 12%. So there was a really reasonable amount of late recurrent HAP and VAP, and that was around 33 days on average post their first diagnosis. So I think that was quite interesting. About 20% recurrence rate for the HAP-VAP, a bit less than the HAP-specific group. And of the cases who did have a relapse, or reoccurrence I should say, 80% of those were the same bacterial pathogen again, and Pseudomonas was the largest proportion of those same pathogen reoccurrences. I found that quite interesting. It makes you sort of think about why that's the case. We need to probably better understand that sort of post-antibiotic microbiome changes. It would have been great to see some patient risk factors thrown in here, because that probably would have put me to understand whether there were things that happened post that first initial HAP-VAP case that could have been modified in terms of patient care or patient-level demographics. But nonetheless, I think that's still an important message.
Okay, we're wandering around the exhibition and Brett's dragged me off to have a look at a poster. Come on, Brett.
Yeah, well, this relates directly to the cleaning study that we presented some results on yesterday. So, of course, that's going to
float your boat.
Float my boat.
Yeah.
So, look, this is a study undertaken in the US. Kristen Gibson is the lead author on this paper. And the title of it is Transmission of Multi-Drug Resistant Organisms During Physical and Occupational Therapy Appointments at 3 VA nursing homes. When I saw the title, I thought two things. One, you don't see much around physical and occupational therapy.
No, you really don't.
And that was like, wow, that's good. And then the second, I thought, in nursing homes, even better.
Yeah. So although a nursing home in the States isn't quite like a nursing home in many other countries. So there's a rider on that one.
Very true. So what they were interested in is they wanted to characterise MRO transmission on hands and equipment. So what they basically did was they sampled patients' hands and surfaces before having an appointment, and they sampled them after their appointment. So beforehand, they suggested that 31% of patients, see again, that's probably, we probably call them residents.
Yeah, residents, yeah.
Had at least one MRO on their hands.
So they were bringing things to their appointment. Yeah.
Yes. And twice as many surfaces were MRO positive at the end of their appointment compared to the beginning, 6% versus 3%. And I think that's important because it's this sort of dynamic between the hands and the equipment.
Yeah, it does mean they're getting the therapy as well, which is good.
Yeah, it does mean they're getting the therapy, so it's not stopping them from getting it. But it highlights for me how important the hands and equipment are at interaction.
Yeah.
Even in setting, we always focus on high-touch surfaces in hospitals.
Yeah.
And we focus on bed rails and call bells, quite rightly so.
Yeah.
But there's this thing called shared medical equipment that doesn't get cleaned very often. And in diverse groups and diverse settings, including, having rehab and using OTs and physios, we still need to be thinking about this transmission.
Yeah.
Now, it doesn't mean it's going to cause infection on anyone, of course.
No, but it means they're going to take something back to the home. I mean, if they're leaving...
Well, they caught something. Oh, yeah, that's right. If they've got someone else's MRO.
Yeah. Well, that's what the poster doesn't say, doesn't it? It doesn't say whether when they left. I mean, the amount on hands is fairly similar, I think. But when they leave, are they coming back with a different one? Yeah, that'd be even worse, wouldn't it? Are they swapping?
I think it was a reasonable amount of swabs. 2,000 surveillance swabs.
Yeah.
Over 200 appointments. Looked for Staph aureus, VRE, and multi-resistant gram-negatives. A composite sort of outcome. So the great conclusions were that patients are arriving with MROs on their hands.
Yeah.
Portable equipment, is commonly contaminated, and they showed that screening, swabbing before and after.
Yeah.
And we need some interventions. I reckon those interventions are quite simply
Yes.
wash your hands when you get there and wipe down your kit afterwards.
Ask your client when they come in for therapy to clean their hands.
Yeah.
I mean, that wouldn't be rocket
clean their
science,
hands and clean their equipment
I
afterwards.
suspect that never comes. So there's messages here for physical therapy staff. I
Yeah,
think.
absolutely.
Yeah.
And probably broader than that about shared medical equipment. But
Yeah.
Anyway, thanks, Barton.
Lovely. Okay, we're still wandering around the poster section, and Phil's found one that piqued his interest, probably because he's going to spend a fair amount of time on planes over the next few days. So tell me about this one, Phil.
Yeah, thanks, Martin. It does sort of have some familiarity with me because I've not always wondered, but I've often wonder whose job is it to empty out the airplane's toileting systems and why, what a job that would be. But we've got a poster from Thailand. Where is it? Department of Disease Control, Ministry of Public Health from Thailand. And it's titled Aircraft Lavatory Wastewater Surveillance for SARS-CoV-2 and Other Coronaviruses by Using Family-Wide RT-PCR. But I don't know too much about the technical laboratory terminology here, but essentially what they have done is they collected lavatory wastewater from aircraft between October and November 2023 at one of the Thailand airports, and sampled the wastewater. And what they found was that a total of 40 lavatory wastewater samples from 20 flights were collected. They were from 19 cities and 17 countries, and one of them was from Australia, 8 from Asia, 8 from Europe, 2 from the Middle East, and 1 from Africa. And 13 of 40 samples were positive for SARS-CoV-2 by real-time PCR. They then go on to talk about other types of coronaviruses that they also identified, and multiple pathogens were detected in 5 samples. So it's quite a niche. I wouldn't want to be doing this study, but it's much easier to read the poster than it would be to do the study. Not only was SARS-CoV-2 detectable at aircraft lavatory wastewater samples, but they also successfully identified some other coronaviruses, and suggests that this sort of sampling or surveillance plays a crucial role in future novel corona pandemics as a screening process. So good luck to them. I'm glad they did it. And,
I'd love to know what the other pathogens were, I have to say. But I suppose it would be an extremely long list, but...
Yes, no, they don't.
No, they're not.
They're not listed.
No, they're not listed.
Not listed. But I guess you'd find a whole potpourri.
Yeah, you really would. And maybe not, from who knows how many flights ago. And that would be the thing about this. How long would these viruses remain viable enough in toilet water? Was it that particular flight, or... because I can't imagine they're thoroughly disinfecting the toilet system in between every flight.
Well, that's right. And, there's another transmission mode is, airplane lavatories.
Yeah.
I guess, isn't it?
You
contaminate all the surfaces in the lavatory, and there's your that's the way that COVID's going to get into your country.
I can see somebody sampling sink drains in lavatories.
Yes, indeed.
That's the next step on, isn't it?
UV lights in lavatory toilets.
Yeah.
Toilets, yeah. Excellent.
Lovely, thanks.
Brett here again, and looking at a poster at ESCMID on enhancing feedback and implementation of infection risk findings among healthcare workers in nursing homes. And it's a study by Yvonne Hendricks in the Netherlands. It's short and sharp, this one. I really quite like it. So there's an environmental risk scan that presumably is required or does happen in the Netherlands, or it's a tool they use in the Netherlands to evaluate infection control programs in nursing homes. I haven't seen it, so I don't know what that's like. But it does focus on a number of parameters like inappropriate use of antimicrobials, environmental contamination, personal hygiene protocols, infection control preconditions, and spread of certain infections like ESBL. And it looks like they had it in place for some time, and then they decided to develop what I would call as a spider diagram. And on the outside of the circle, they have all the different components of the risk scan, so things like inappropriate use of indwelling medical devices, environmental contamination. So imagine all those around the outside of the circle. And then compliance with those, or not compliance actually, they've measured it as high improvement needed, intermediate improvement needed, or low improvement potential. And they put a dot around the outside. So the closer you are to the outside, the higher the improvement potential there is. And the closer you are to the middle, the lower the improvement potential. So that being things are quite good and don't really need to change too much. So they've got this little visual diagram, which I really like. And they use that as a way to provide feedback to staff. I also really like the wording, low improvement potential and high improvement potential, rather than compliance or other words we might use. And they use this as a concise and a feedback loop to healthcare workers to try and engage them with this environmental risk scan. And they felt their sort of suggestion was that healthcare workers liked it. They felt more motivated to make enhancements, and they had more active participation in quality improvement efforts, and that they felt this ultimately is going to improve and enhance patient care and organisational performance. So, nice little visual tool that might be worth considering. Thanks.
So I wandered around the exhibition, bumped into a nice poster about glove use, multi-centred before and after regional de-implementation study. And I'm with Anne Forntolt and Juliet Severing from the Netherlands, and we'll have a little chat about that. So what did you do, Juliet?
Yeah. Well, actually, this project started when COVID-19 was in the second wave, and there was a threat of having a real shortage of gloves. Okay. And then we thought, what should we do? But actually, at that moment, our infection control team and we all said, well, this could be a good moment, because we know that gloves are often used on moments that we should not use it, or the nurses and doctors should not use it.
Yeah.
So we thought maybe we can take this opportunity and then really make a project on really using gloves in a proper way.
Yeah, and so never waste a crisis is what they say. So.
Exactly. So at that moment we started with measuring what was the use of gloves at that moment, and we also found out there was not a real system to measure good use or proper glove use.
Right.
So we made a very easy system to score that, and then we made the scorings, and we discovered that, as it was expected, that gloves were often used when they should not be used. We also had very nice discussions with nurses, actually, like what is the moment that you should use gloves and not use gloves, and why are you using gloves in these moments? For example, washing a patient, is it really necessary to use gloves when you wash a patient? And then the funny thing was that all the nurses said, no, we don't use gloves when washing patients, but the younger nurses all said yes, of course, because otherwise we feel dirty, or we feel that our...
There's a generation thing going on.
There was a generation thing actually going on. So, and after that the team actually, we did it with 11 healthcare institutes in the Netherlands. So together with the team, a toolkit was made to make people aware of this improper use of gloves. And one of the other things that we also notice is when people are grabbing the gloves from the boxes, you want to grab 2 gloves.
Yes.
But then usually the gloves are not very well put together in the box, and gloves fall out and they fall on the ground, on the floor, and then you throw them away because you cannot use it. So there's a real waste of gloves in these moments.
Okay.
So we also focused on that. So several interventions made, and then we did again the scoring about the proper glove use after, and we actually saw a nice decrease, although it's not completely statistical.
No.
This one is.
Yes.
So now I'm giving the word to Anna.
And so what was really important as well is that we made a regional policy about glove use.
Okay.
Because that was that differed between the centers, and before you can actually score and show results of such observations, you should develop a regional policy.
Yeah.
So that was actually the first step. And then you can score them whether they should wear gloves, so is there an indication or not.
Yeah.
And if there is an indication, is the health worker actually wearing them?
Yes.
Or not?
Or not.
And when they should not wear them, are they actually wearing them or not?
Okay.
This one, that's quite good.
Yeah,
Over
most of the time,
90%.
if they should wear gloves, they do.
They do.
Yeah.
That's actually quite good because
But
this
given
one
that they're
is-
wearing gloves all the time,
Yes, because this one is that's dangerous.
Yes.
Of course, when they should wear them
And
and
they don't.
they don't.
Yeah.
But that's quite low.
It
That's
is good,
good.
yeah.
That's good. But when they should not wear gloves, according to our regional policy, 40% is actually still wearing them.
yes.
And we want that number to go down.
Yeah.
And it did.
Yeah.
So it went down from 42 to 35%, and that was statistically significant. And should not wear gloves, actually is not wearing them. It's like, yeah, it went up a bit, of course. But when they're wearing gloves, so in this section and that section, are they actually wearing them correctly?
Yeah.
60% of the healthcare workers do not wear them correctly.
No.
And
that didn't
that's
change
quite
that
striking.
much.
No, that
No.
didn't change. And that's quite striking, actually.
Yeah, okay.
That's a high number.
Yeah. So do you think of the Com B, which is the one you're now going to have to target more to be able to change that? Is it motivation, opportunity, or behaviour?
Now you see opportunities goes lowest.
Okay.
And we also looked whether that differed between the healthcare centers, because we included hospitals and nursing homes, so long-term care facilities, and it actually was the same pattern.
Oh, really?
So opportunity is always lowest and behavior is always highest.
Okay.
But we're currently, because these are preliminary findings, we're still investigating this,
Okay.
and we're deciding our next step, because
Yeah.
the second round of the project just kicked off. So we're currently recruiting healthcare centers for a second round of proper glove use, de-intervention.
So indications
And,
it is
yeah.
working, but I'm afraid this is a long-term piece
It
of
is.
work, isn't it?
Yeah.
Because often people's beliefs are very entrenched.
And so I think it's similar to hand hygiene.
Yes.
This goes hand in hand with hand hygiene.
Quite literally.
Yes.
Okay. Well, thank you very much. Thank you, Juliet. Well, thanks everyone. I hope you've enjoyed the poster sessions. We really enjoyed it. We wish we had more time in it. Unfortunately, all of the IPC related stuff was put on the last day where many people have to dive off for flights, which is a bit of a shame. If they'd have been spread throughout the conference, then there would have been more of interest every day and we'd have had more time. But however, they are there and we've got access to them afterwards, and it's fair to say, Brett, we've really enjoyed them.
Oh, they've been fantastic. And apologies if you were here, we didn't get a chance to mention your poster.
Yeah.
Yeah, look, I've really enjoyed it. I reckon this has been one of the best parts of this conference.
Yep, as always.
As always, yeah.
Cheers, everyone.
Cheers, mate.